Hello, everyone. My name is Motoko Yanagita, Vice President of JSN and Professor of Kyoto University, Japan. Everyone, welcome to the fourth joint meeting between the ERA and JSN. The two societies have been strengthening their ties for more than 10 years. Last year, we held a joint symposium titled Kidney Health in Aging and Age Society, led by Professor Wanner and President Nangaku. This collaboration has brought the two societies together and produced significant results. However, for this collaboration to continue, it is important to strengthen the relationship not only among the current leadership, but also among the younger generation. In that sense, I am very happy that this joint meeting was being held for the fourth time. I'd like to express my sincere gratitude to President Torra and President Nangaku for their continuous support, and Oshima and Megumi for their kind preparation of this meeting. Here, I'd like to briefly introduce the participants from JSN. At the beginning, we will hear messages to young nephrology scientists from Professor Naoki Kashihara, immediate past president of JSN, professor at Kawasaki Medical School Hospital. Subsequently, Dr. Megumi Oshima of Kanazawa University, who plays a central role in the YNP of JSN, chairs the meeting. Dr. Shuichiro Yamanaka of the GK University School of Medicine, who achieved remarkable results in the field of regenerative medicine, will give a lecture. And I think Megumi will provide a more detailed introduction of him later. Last but not least, President Masaomi Nangaku, Vice Dean and the Professor and Head of the Division of Nephrology and Endocrinology at the University of Tokyo, provides closing remarks. Now, I'd like to invite Oshima, the chair of YNP of ERA, to make opening remarks. Oshima, please.
Thank you very much, Professor Yanagita. Good afternoon and good evening, dear distinguished colleagues and friends. It's really an honor to welcome you, all the speakers and the participants, to the fourth joint meeting of the Japanese Society of Nephrology and the Young Nephrologist Platform of the European Renal Association. So I'm Orsolya Cseprekál, a transplant nephrologist at the Samoves University Budapest and the current chair of the YNP in European Renal Association. So on behalf of the YNP board, I thank ERA and JSN Council for supporting this event and this collaboration, which exemplifies the power of shared vision and international cooperation in advancing nephrology. This gathering is more than an exchange of knowledge, so it's a bridge connecting nations, fostering dialogues and building networks that will endure. Together we are creating, let's say, a legacy for the future generation, empowering young nephrologists to address global challenges and further innovations and further confidence. A partnership between the JSN and the ERA has opened new opportunities for mentorships, research, and professional growth. It reminds us that the most pressing issue in kidney health are best tackled through collective wisdom and collaboration. So as we begin this meeting, let's embrace this opportunity to learn from one another. The topic of this meeting covers living donor transplantation, insights from Japan and Europe. I wish you all a productive and enriching meeting, and thank you for your dedication to this advancing kidney health. So before starting the meeting, I would like to introduce Professor Wanner, who will represent the ERA and send some messages for the young scientists. Professor Wanner, who is a past president of the European Renal Association, he is a senior professor of medicine in the Department of Clinical Studies and Epidemiology, University Hospital of Würzburg, and a visiting professor of renal medicine at the Nuffield Department of Population Health, Clinical Trial Service Unit, University of Oxford. Later on, Rita Leal will be the speaker from the ERA YNP side. I will introduce her a little bit later during the session. And finally, Professor Rosa Torra, the current chair of the European Renal Association, will close the session. She's actually a president of the ERA and the chair of the inherited nephrology at the Fundació Pigvert and professor of medicine, Universitat Autonoma de Barcelona in Spain. So herein, I would like to introduce the next two welcoming words and the messages for the young nephrologist. First, Professor Kashihara, and then Professor Wanner. Thank you.
Ladies and gentlemen, dear colleagues and young investigators, good morning and good evening, and welcome to this joint symposium organized by ERA and JSN. It is truly an honor to open this exciting session, which brings together brilliant young nephrologists from Europe and Japan. This event is a unique opportunity to exchange ideas, share knowledge, and foster meaningful international collaboration. So I would like to express my sincerest gratitude to Dr. Orsolya, Cseprekál, and Motoko Yanagita for their strong leadership and coordination in making this symposium possible. My heartfelt thanks also go to Professor Chris Wanner, Professor Rosa Torra, and Professor Masaomi Nangaku for their continuous support and inspiring messages to next generation. I'm also grateful to Dr. Megumi Oshima for her dedication. To all the young participants, I encourage you to fully engage with today's program. Take this chance to build connections and explore future collaborations. This is more than a scientific meeting. It is the beginning of friendship and networks that will shape the future of nephrology. Thank you very much once again, and I wish you all a stimulating and enjoyable symposium. Thank you.
Hello, my name is Christoph Wanner. I'm the current past president of the European Renal Association, and I'm very pleased to give some introductory remarks. The ERA is very proud to have this session with the Japanese Society of Nephrology. Why? Because we hear cutting-edge science from our experienced speakers, but we also bring our young nephrologists, our next generation, to visibility for an international audience on this platform. The young generation needs some recognition and visibility. And yes, this is a type of mentoring program the society is doing for the next generation, the members of the Young Nephrology platform of the European Renal Association. So I wish this session a lot of success, and looking forward to see you at the 62nd Annual Congress of the European Renal Association in Vienna at the end of next June. Thank you.
Thank you, Professor Kashihara and Professor Wanner. And good morning or evening, everyone. I am Megumi Oshima from Japan. And together with Dr. Orsolya from Hungary, I have the pleasure of chairing this fourth joint meeting between the JSN and ERA YNP. We now come to our main topic, kidney transplantation from living donors, insights from Japan and Europe. Before we begin with our presentations, I would like to explain the format of our session today. We will have two comprehensive presentations each lasting about 20 minutes. Following both presentations, we will have approximately 10 or 15 minutes discussion period. We can explore similarities and differences between Japan and Europe. This interactive format will allow us to exchange ideas and perspectives from both Japan and Europe on this important topic. For our first presentation, I'm delighted to introduce Dr. Shuichiro Yamanaka from the JK University School of Medicine in Tokyo, Japan. Dr. Yamanaka is an assistant professor in the Division of Nephrology and Hypertension at the JK University School of Medicine. He received his MD in 2006 and completed his PhD at the same institution. He is a board-certified nephrologist and also specialist in regenerative medicine, with his research focusing on organ regeneration and xenotransplantation. He will today speak on living kidney transplantation and xenotransplantation, current status, challenges, and future perspectives. So, Dr. Yamanaka, please go ahead. You are muted.
Okay. Sorry. Okay. Good morning. Good morning and good afternoon, everyone. I'm Shuichiro Yamanaka from JK University, Tokyo, Japan. I'd like to share the latest insights on kidney transplantation with a focus on xenotransplantation. Thank you for the opportunity. I look forward to our discussion. I have no COI to declare. I'm a nephrologist engaged in both clinical practice and research, with a research interest in organ regeneration and xenotransplantation. Currently, my laboratory is exploring the use of fetal pig kidneys for this purpose. Today, extending from my expertise, I will discuss recent trends in xenotransplantation targeting adult patients, along with its potential clinical application. Do you notice a commonality among the 4 people shown on this slide? They are the world's first recipients of genetically modified pig kidney transplants. This strongly indicates that xenotransplantation using pig kidney is rapidly approaching clinical reality. Let's look at the current state of renal replacement therapy in Japan. As the graph shows, nearly 350,000 patients rely on dialysis. In stark contrast, the total number of kidney transplants performed annually represents only about 0.5% of these patients. Furthermore, over 14,000 patients are on the waiting list for a deceased donor kidney, facing an average waiting time of around 15 years. This highlights Japan's heavy reliance on dialysis and the huge gap between the need for transplants and their availability. This organ shortage isn't just a Japanese problem. It's a critical global issue. Looking at the US data, over 100,000 people are on the overall waiting list for an organ transplant. The tragic consequence is that about 70 people die every day in the US while waiting. The situation is similarly serious in Europe, with around 20 deaths daily among those waiting. The situation is similarly serious in Europe. This profound unmet need underscores the urgent search for alternative organ source like xenotransplantation. Now, I'd like to shift our focus to xenotransplantation, which has seen remarkable progress recently. While early research explored organs from non-human primates, the field has largely converged on pigs as the most valuable source. Let's look at why. Pigs offer several critical advantages, as highlighted in this comparison. They provide an unlimited supply, breed efficiently with rapid growth to suitable organ size, and tend to have better public acceptance as livestock animals. These factors make pigs the preferred source for xenotransplantation. Xenotransplantation faces a major hurdle, an immediate and severe immune reaction. This pig kidney transplanted into a baboon was destroyed in just 10 minutes. This rapid destruction is called hyperacute rejection, a barrier specific to xenotransplantation. It begins as preformed antibodies bind pig endothelial xenoantigen. Complement is then immediately activated. This cascade results in endothelial damage, inflammation, thrombosis, and hemorrhagic graft destruction, occurring within minutes to hours. Effectively block this antibody complement-mediated attack was the essential first step toward successful xenotransplantation. Xenotransplantation research was revolutionized by CRISPR-Cas9 genome editing. This technology made it possible to precisely and efficiently modify key pig genes. It was truly a game changer. Two key technologies, genome editing and improved immunosuppression, have driven recent progress in xenotransplantation. As this graph clearly shows, maximal survival times increased dramatically in the 2010s. Breakthrough in genome editing were a major factor driving this marked change. This slide outlines the gene edits designed for human compatibility. The 10 GE pigs being used incorporates these 10 edits, 3 knockouts of major xenoantigens, and 7 insertion of humanizing factor. Effective immunosuppression is also key for xenotransplantation. The anti-CD154 antibody, in particular, is now essential. By blocking CD40-CD154, it suppresses both AMR via B cells and TCMR via T cells, APCs, while also promoting Tregs. This broad effect makes it indispensable for xenograft survival, although is not approved for clinical allotransplantation. The combination of gene editing pigs and novel immunosuppressive therapies has dramatically improved outcome in primates. As the results show, adding the 7 human transgenes to the 3 knockout pig background was crucial for extending kidney xenograft survival greatly in cynomolgus macaques. Using the 10 Gs pigs, this study achieved remarkable long-term life support in cynomolgus macaques exceeding 2 years. However, the graft histology from the longest survivor revealed marked chronic activate antibody mediated rejection with C4D deposition, indicating that rejection control was incomplete. Learning from both the success and challenges in these primate studies, and after years of basic research, the field began to move towards clinical application in humans. Before, living patient trials, studies in brain-dead recipients provided crucial data using genetically edited pig kidneys. Visually, the kidney remained viable, and importantly, histology confirmed no hyperacute rejection over the 54-hour study period. This was key proof of concept. Now let's look at the function. Functionally, the transplanted pig kidneys showed good variability. Kinetic GFR increased and substantial urine output was observed. However, interpreting immune response requires caution. As noted, complement is often pre-activated in brain-dead recipients, complicating these assessments. While variable for showing initial function, the model has a limitation for assessing long-term complex immune response. Building on data from preclinical and brain-dead recipient studies, the field soon reached a major milestone: the first transplantation of genetically modified pig kidneys into living human patients. These initial procedures were performed under the FDA's Expanded Access or Compassionate Use Program. This pathway is generally for patients with very severe conditions and limited option for standard transplantation. Let's focus on landmark first case performed at MGH in March 2024. The recipient was a 62-year-old man with ESKD on dialysis, ineligible for a second human transplant. He received a 10G pig's kidney using the immunosuppression protocol shown and was able to come off dialysis. This graph shows the post-transplant course. Kidney function indicated by creatinine and eGFR remained stable for near 2 months. Sadly, the patient passed away around the 2-month mark due to sudden cardiac arrest. Autopsy provided crucial insights into this outcome. Importantly, no major graft rejection was observed. This histology shown here with minimal CD3 cells and C4D staining along with low bar scores supports this finding. Therefore, the death is considered unrelated to the rejection of xenograft. Severe underlying conditions such as diabetes and particular cardiac issues likely played a major role in the outcome. This underscores the challenges of managing critical ill recipients in these initial pioneering transplants. This slide presents the third case of a pig kidney transplant into a living recipient performed at NYU. While this 53-year-old woman was in better condition overall compared to the first case, she still qualified for compassionate use. This was because her condition was worsening. She had developed very high level of antibodies, making a human match nearly impossible within years. And critically, she was losing her blood access. The 10G's pig kidney was transplanted last November. As of April, 4 months later, she is alive and her progress is reported to be good. The 4 initial compassionate use cases in 2024 provide valuable early human experience. However, launching formal trials required robust clinical support. Expert opinion called for demonstrating consistent 6-month survival NHP models. Encouragingly, this milestone was met, as 80% NHP survival beyond 6 months was reported. This pivotal preclinical success paves the way for FDA approval of a formal clinical trial slated to begin the summer 2025. As outlined here, this structured trial represents a critical step forward from the initial compassionate use cases. Beyond the immunological and infectious hurdle we have discussed, several other major barriers need to be addressed as highlighted here. These include physiological difference between pigs and humans that need careful management. There are also critical social and ethical considerations, and we must consider the practical healthcare resource implications. Addressing this wide range of challenge is crucial for the responsible clinical application of xenotransplantation. Finally, I'd like to briefly touch upon a different, though related area, which is the focus of our research. Exploring the potential of fetal donor kidney transplantation, primarily aimed at addressing severe congenital kidney disease like Porter syndrome. Our specific research is motivated by a critical unmet need. Severe congenital unuric kidney failure currently lacks effective treatment. Standard RRT is extremely difficult in newborns, resulting in very poor survival. This drives our search for alternatives. To address the challenges just mentioned, our concept is to use fetal pig kidney transplant as a bridging therapy. The goal is allowing growth until standard RRT becomes feasible. This approach leverages the potential advantages of fetal tissue outlined here. Small size, natural vascular integration, and lower immunogenicity. Building on that concept, this slide demonstrates the functional potential of fetal kidneys. We transplanted donor fetal kidneys into adult rats after removing their own kidneys. This enabled survival for over a month. Histology confirmed the tissue reached maturity by 8 weeks and underwent spontaneous vascularization, showing its capacity to develop into functional structures within the recipient. This slide shows our fetus-to-fetus kidney transplant experiment in rats, representing the first successful in utero transplantation of fetal donor kidney. As shown here, the transplanted fetal kidney successfully grew within the recipient fetus in utero. After birth, this tissue matured and demonstrated function by producing urine. This successful proof of concept in rats provides the foundation for progressing our research to pig to NHP transplantation models. I would like to express my special gratitude to my supervisor, Professor Takashi Yoko, for his invaluable guidance throughout our research. I also thank my dedicated colleagues and all collaborators involved in project. Thank you for your attention.
Thank you very much for this comprehensive overview and very interesting data. So I'm pretty sure that we are going to have a lot of questions, and I also would like to encourage the participants to ask their questions in the Q&A box. Meanwhile, I'm introducing our next speaker from the European Renal Association, Dr. Rita Leal, graduated from University of Coimbra in Portugal, and she completed her nephrology training at the University Hospital of Coimbra, Portugal as well. Again, she holds the European Certificate in Nephrology from the European Union of Medical Specialists. She's currently an assistant nephrologist in the kidney transplant unit and an assistant professor at Coimbra University. Additionally, she is pursuing a PhD at the same university, working on a project aimed at improving outcomes from kidney transplant patients after graft failure. She is involved in multiple national and international projects, including a multicentric study with Columbia University, New York, USA, on the recurrence of glomerular diseases in kidney grafts. So please, Rita, I would like to ask you to hold your presentation. Thank you.
Thank you very much for your kind presentation. And also, I want to greet the chairs, all the colleagues, all the participants. Dr. Yamanaka, thank you so much for your interesting presentation. And also, I want to thank ERA for the kind invitation. It is a great honor to participate in this joint seminar, and I am also very pleased and slightly flattered to still be considered a young nephrologist. So thank you so much for that. Today, I will talk about living kidney transplantation in Europe, some insights, ethical changes we face, and future directions. I will focus on the present, how are we doing now, and how can we improve living transplantation in Europe, and I will focus more on human studies. Oops, sorry. Okay, so this is my disclosure of interest, and I will start my presentation by giving a view of end-stage renal disease in Europe. It is highly prevalent, especially in my country, Portugal, and there are over 500,000 people in dialysis in Europe. As we all know, this is associated with low quality of life, high mortality, and important economic burden. Indeed, the costs of dialysis, they represent almost 3% of the total national health budget in Europe. And kidney transplantation is the renal replacement therapy associated with the best clinical outcomes in selected patients. I think this graph from the ERA registry is really informative. So data shows that patients undergoing transplantation they significantly improve their expected remaining years of life, especially for young individuals. And this benefit is even more evident in the case of living donor transplantation. Living donation, usually donors are healthier, and it's an elective procedure that more easily enables preemptive transplantation. It involves less and short cold ischemia times, avoiding inflammation associated with brain and circulatory death, and from an immunological perspective, it can offer better compatibilities and make transplantation possible in challenging patients, especially clinical and immunological complex patients. Fortunately, we can see the benefits in the large databases from the US, United States. They show us the results from databases including thousands of patients, and we can see that I'm sorry, I have to move here. Okay, so you can see that graft survival in the first year, graft survival for deceased donor is 94% compared with 97%. And if we move further in the 5th year post-kidney transplant, living donation is associated with an increase in 10% of the survival rates. Oops. Okay. And so how are we doing in Europe regarding living transplantation? I'm sharing the most recent data from the ERA registry, which of course needs no introduction. In 2022, the annual kidney transplant rate in Europe was around 45 transplants per million people for countries that provided individual data. When it comes to living transplantation, the numbers are considering low, with an average of just 10 transplants per million people. There is also significant variation between countries within living donation rates, ranging from 0 to 28 per million people in the UK and the Netherlands. And there is an explanation for this variation. That is the opt-in, opt-out system. It's important to note that the countries that have highest living donation rates tend to have an opt-in system. In an opt-in system, individuals must actively consent to donate their organs after death, whereas in opt-out systems, consent is presumed unless a person states otherwise. And you can see that the countries with largest living donation rates are those with an opt-in system. This was actually evidenced in a recent manuscript published in Kidney International. But in countries with opt-in systems, the living transplantation rates are almost 3 times higher than in opt-out strategy countries. I also found this study very, very interesting. This is a paper from the ERA registry group that shows how European kidney transplant activity has evolved in the last decades. And they analyzed the transplant rates per million population and annual percentage change from 2010 and 2018. And as you can see, the results show that the absolute rates from deceased donor transplantation are significantly higher than the absolute rates of living donor transplantation, so around 30 versus 6. And also, despite the absolute rates are bigger for deceased transplantation, the growth in the number of transplants is also increased more in deceased donor transplantation. So 1.9% from 2010 to 2018 versus 1.6%. And as we all know, considering that there is a scarcity of organs and a lot of people in dialysis, there is obviously room to increase living donation. And if we optimize living kidney donation, then kidney transplant rates can substantially increase in many European countries. Now, how can we do this? How can we expand living kidney transplantation? And there are 2 main strategies to do it. First, by implementing educational programs that should target not only the general public, but also healthcare professionals. It's particularly important for those discussing renal replacement therapy to introduce the topic of living donation and increase the chances of preemptive transplantation. I leave you here. This is a Portuguese slogan that was published in the news. It says, "To donate a kidney is good for your heart." And it's just an example of how we are also sensitizing people in general population for living kidney donation. The second strategy to broaden living donation is to accept not only genetically related donors, which was the normal practice until the mid-80s. Nowadays, there are other strategies in living donation, and I am showing you the ones that are accepted by the ESOT and the ethical, legal, and psychological aspects of organ transplantation. So you have specified donation where you which includes like direct specified donation, genetically related donor and recipient, or emotionally related donor and recipient. You also have specified donation, but indirect donation, where you have an indirect donation to an intended recipient, or unspecified donation, which is also called altruistic donation, when you have a donor to an anonymous, unspecified recipient. I will focus now on indirect donation, which is also called kidney pair donation. So why is it important? Well, around 40% of living donor pairs are incompatible, mostly due to OHB0 or HLA mismatch, but sometimes also because of differences in body surface area. And through specified indirect donation, like paired or pooled exchange programs, a patient with a willing but incompatible donor can swap the donor with that of another participant, another patient in a similar situation, making transplantation possible for both. And indirect specified donation offers several advantages. In one hand, it expands the living donor pool, avoids desensitization protocols and the associated morbidity and mortality and the costs of these desensitization protocols. On another hand, it increases the chances of kidney transplant in challenging patients, such as the highly sensitized patients. And as explained by this interesting and very important study with similar graft and patient outcomes. So this was a large cohort study that involves over 2,300 patients that were submitted to a kidney transplant through a national kidney pair donation, and they compared the outcomes with living donors, non-pair donated donors, or with control unrelated living donors. And what they found were similar graft survivals and similar patient survivals after 7 years post-kidney transplant. And so in Europe, kidney pair donation started in 2004 in the Netherlands. And there are very well-established programs, such as the Netherlands or the UK. For instance, in the UK in 2017, around 1,000 transplants were performed through these programs. But other countries are still small or are preparing these programs of kidney pair donation. Why? Because they are logistically complex, and in most centers, they require the establishment of centralized coordination teams. Advanced softwares are needed to enter donor and recipients pairs, to run potential matching algorithms, and obviously there are also legal and ethical considerations, including the mandatory maintenance of anonymity between pairs. On the emotional side, also, the donor's sense of altruism towards the intended recipient may feel diminished in a periodic exchange with higher anxiety levels. Even in well-established kidney exchange programs, there are important limitations. And the major challenge, especially in small countries, is that as the donor pools decrease, the diversity of potential donors decline, leading to an accumulation of blood group 0 recipients and highly sensitized patients. In countries with permissive legal frameworks, supportive policies and established kidney exchange programs, these programs can be further enhanced. How? By including compatible pairs that might improve. So including compatible pairs is good because it can promote more changes and more runs, but it can also be better for the pair that is compatible. We can increase, for instance, HLA matches or have a better age or body surface area match. Also, you can include unspecified or non-direct altruistic donors that we will talk a little bit further, and also include deceased donor kidneys. A program that is growing, and it's increasingly growing in the last years, is the international exchange programs. And Also, there are networks, including the European Network for Collaboration on Kidney Exchange Programs, that can help with the technical limitations and improve these international exchange programs. In this graph, I'm showing you a summary of the characteristics of European kidney exchange programs that already exist. And you can see there are several differences between them. In some of them, altruistic donor is possible. In some of them, compatible pairs can participate, and other programs, incompatible transplants, can also integrate these exchange programs after the sensitization strategies. And importantly, what you can see is that for countries that are less restrictive in the inclusion participants, such as the UK, the numbers of performed kidney transplants through these programs is increasingly high. So international kidney exchange programs, they already exist. The South Alliance that includes Spain, Italy, and Portugal is growing. It started in 2018 with 2 recipients. I'm not sure about the current numbers. They are not published yet, but I can say that at least in Portugal, since the last 4 years, 5 recipients were transplanted through these international exchange programs, and all the recipients were highly sensitized with CPRIs of 100%. The United Kingdom and Ireland also have international exchange programs, as well as Austria and Czech Republic. And as far as I know, there are other programs starting, including a program with the US and Italy, and a transplant has already happened between 2 American cities and Denmark. Also, another way to expand living kidney transplantation is to include unspecified donation, also called altruistic donors. In this case, a healthy, let's say, Good Samaritan donates a kidney to a non-designated recipient based on medical urgency and compatibility. In most centers, when an altruistic donor is available, they are entered into a kidney exchange program to see if they can start a transplant chain. These donors are on the rise, and you can see here, these are data from 2018. In the UK, there were 700 unspecified donors already, and the impact that they can have in starting kidney pair donation chains is huge. So in 2019-2020, of the 95 non-specified donors that exist in the UK, 47 entered a kidney pair donation chain, and they resulted in 122 transplants, of those 4 children transplants. Of course, the main limitations to unspecified donation lie in the ethical sphere. There is often skepticism about the motivations of healthy donors, so a strong legal frame is essential. The Council of Europe requires that each country define its own legislation on this matter. And increasing social awareness is also a key for the growth of these programs. And as a curiosity, we had our first altruistic donor in 2020. And after that, it was announced in the local news. And the following week, we had a lot of phone calls to our transplant unit of people that wanted to be altruistic donors. And I'm finishing my presentation by talking in some general ethical challenges that exist with living transplantation. The European Union Directive on Organ Donation lays out the core ethical principles that guide living donor kidney transplantation: autonomy, beneficence, non-maleficence, and justice. But the primary goal is to ensure donor safety, and the team will refuse donation in case of a negative benefit-harm balance, sometimes even despite the donors willing to donate. To achieve this, we must fully understand the risks, explain the risks, carry out a thorough donor evaluation and identify any potential concerns, guarantee truly informed consent, and ensure proper follow-up of our donors. Regarding long-term risks of living donation, there is a paper, a review and position of the ERA Eritrea Descartes working group. And there was some worries regarding long-term risk kidney living donation with the publishing of two large studies, one from Norway and one from the US, where they found for the first time that end-stage renal disease incidence was higher in living donors than in controls. The relative risk of end-stage renal disease in the Norwegian study was 11 times bigger, and for the US study was 8 times bigger. However, we need to look at these results with caution. On one hand, despite the increased relative risk, the absolute risk remains low. And on the other hand, the majority of the donors in the Norwegian study were first-degree relatives, and end-stage renal disease was mainly due to new onset immunological-mediated renal disease. On another hand, in the USA trial, 83% of the end-stage renal disease occurred in first-degree related donors. However, the matched control cohort did not provide information regarding family history of end-stage renal disease. So perhaps these bad results are a consequence of a selection bias. And let's not forget, I think we always need to go back to 1954, when the first successful living transplant was performed between two twin brothers. And the donor, Ronald, died in 2010 at 79 years old, which was slightly above the life expectancy of that time. Informed consent is of utmost importance. The Descartes working group proposes a 3-step model that is available online. Step 1 starts at end-stage renal disease of the recipient with the assistant nephrologist, and it's time to acknowledge all the options. Step 2, that might take up to 3 to 6 months and consists of individual appointments with a different nephrologist from the one of the recipient. And step 3 is the formal assessment and signature of the informed consent. It is fundamental to explain that the decision of being a donor can be withdrawn at any time of the process. And last but not least, I also feel it's very important to acknowledge the ongoing migration crisis in Europe. And even after legal integration, migrant patients often face greater barriers to accessing transplantation and are more vulnerable to organ trafficking. It is essential to ensure that living donation remains fully voluntary and carried out on a non-profit basis. The Council of Europe addresses this issue particularly and says that we need to pay particular attention to cases where the donor is not a resident of the member state concerned. So these are my take-home messages. Living donation has several benefits, as we all know, not only for the recipient, but also the donor and the society. Living donation rates in Europe are variable, and there is only a modest increase in the last decade. There is room to grow, and several strategies to increase include raising awareness, kidney exchange programs, and altruistic donations. Obviously, we all need to be aware of the ethics, legislation, and government directives for donor protection. So thank you very much. I leave you with a picture of my hometown, and I'm hoping to answer all the questions. Thank you so much.
Thank you very much for this excellent and comprehensive overview. Both presentations were pretty interesting and very captivating. It was really interesting to see the different point of views. So let's see if we have any questions from the audience. I'm just checking the Q&A box. And I'm also asking my co-chair, Megumi, if she would like to ask or add something to the presentations.
Okay, so thank you for very much for excellent presentation to both of you. And I have some questions I would like to ask both of you. And first, Dr. Yamanaka, thank you for sharing the excellent your research. And I hope that in future that patients with Porter syndrome can receive xenotransplantation. But if there are any difficulties or concerns you have when you try to perform xenotransplantation in humans.
Fetus is very small and very implantation is very difficult, and I concern to safety and as a reason and infections if we demonstrate safety and efficacy in non-human primates, we are considering treating newborns born without kidneys as the first xenotransplantation in Japan within a few years at the earliest.
Thank you for your explanation.
Thank you. I can see a question in the Q&A box. So may I read it now? Thank you. So it's It's from Dr. Oda. Thank you very much for your lecture. As European Renal Association encompasses many countries, I wondered if discussions on ethical challenges involve multiple viewpoints from different regions with different culture and history. So have you noticed, I guess that it is for you, Rita, have you noticed any challenges or interesting aspects that derived from these differences?
Yes. Thank you for your question, Dr. Oda. Yes, there is so European Union as a general ethical law, let's say it this way, for non-genetically related living donation, and it started in 2008. So in 2008, all countries should allow for non-genetically related kidney transplants. Regarding kidney pair donations and unspecified donations, the law states that each country should decide what they want to offer to patients. And for instance, in Portugal, I can tell you about my country. In Portugal, kidney pair donation is available, international kidney pair donation is available, and unspecified, so altruistic donation is available. But for instance, in France, this is not the case. So there are, regarding altruistic donors and kidney pair donation, which actually is where we found in our real world practice the most ethical challenges. The law is dependent on each country. So yeah, it's not it's quite variable. This might be a challenge, and is for sure a challenge for international kidney pair donation, because we have to have similar procedures so you can exchange kidneys between countries.
Thank you very much. So it's very interesting, really. I'm just asking if any of the panelists would like to ask something or add something. Yeah, please, Professor Yanagita.
Hey, thank you very much for a great presentation for both of you. And I have one question for each, and I have one question first for Rita. And thank you very much for your beautiful presentation. And in our country, as Yamanaka-san mentioned, that the living kidney transplantation is a major transplantation. And in our country, sometimes that the donor are aged and they are facing problems after donation. And so I'm wondering whether you have some kind of support for the donors, because that they may need some kind of routine screening and routine follow-up after their donation.
Yep. So actually, the follow-up of the donor is legally, there's legislation on that. So it's not just something that I think we all as nephrologists acknowledge that should be done, but you legally have to do it. So you have to have a follow-up appointment with a nephrologist in the first year, at least I think in the first month or in the first 3 months, and then at least annually. Every year, the donor must be seen in an appointment with a nephrologist. Also, there is an obligation for every country to have a registry of the donors, so you can see what happens to the donors, and so we can reflect on our numbers and see if we are doing everything the right way. And obviously, the screening before being a donor, it's also standardized. We have the KDIGO guidelines, for instance, and something that I find interesting regarding the age of the donors is that we should not be afraid of using elderly donors as living donors, because younger donors tend to be healthier when we are evaluating them, but we don't know about the future. But if we are evaluating an healthy elderly donor, and if he is healthy at that point, and considering the lifespan, it's probable that end-stage renal disease will not be a problem. So that's something that is also a little bit changing, I guess, in recent years. So yeah. Thank you. I hope I answered your question.
Thank you very much for that. And can I ask a small question to Dr. Yamanaka as well? Thank you. Dr. Yamanaka, thank you very much for your great presentation. And I have a question for your experiment, for your research. I'm interested in whether erythropoietin is produced by the neonatal kidney from porcine pig, because we know that erythropoietin is not produced before birth, and before birth, liver produces erythropoietin. But I think that there is a machinery in the kidney to produce erythropoietin, and it is switched on after birth. So it's very interesting to see whether the neonatal kidney from pig produce erythropoietin after transplantation to neonate in human. So, and this is my question. I'm afraid that you're muted.
I have no data, but neonatal kidney transplant producing erythropoietin, the growing fetal kidney and same growing functions of producing erythropoietin. anemia's rat transplant fetal kidney. Anemia is already recovering. I think fetal kidney can make produce you erythropoietin.
Thank you. Interesting. Thank you very much for that.
So thank you very much. Megumi mentioned that she would have another question, so if she wants, she can ask, but if not, okay,
Thank you
please.
for remembering. I have a question to Dr. Leal, and currently in Japan, the indirect specified donors are not allowed. It means that to donate one's kidney to the stranger.
No, indirect.
Indirect.
Yes.
So
Yeah.
not direct family, you mean? Like a couple, between couples.
Yeah. So you have it's like the altruistic donation.
Altruistic donation, yes.
Someone that desires to donate his kidney to whoever needs it the most.
Whoever needs to be. So maybe there are some major, it's not allowed in Japan, mainly because of the ethical perspective. So I have wondered, I'm wondering that who are in charge of the cost, or medical cost of the operation and screening?
Yeah. So so there are coordinators in every hospital. This is how it works in Portugal. It's my experience, and I think it's transversal in Europe. So the kidney transplant team receives these potential donors in living donor appointment. Okay. And then the process is similar as if it was a living donor. So we explain the risks, we do the screening, and then we have an ethical team within the hospital that all living kidney transplants go through that process with psychologists, with psychiatrists, with legal people from the hospital, and only then, if everything is okay, and if you realize with different people that don't talk between them, and if everything is okay, then we usually use this donor. This is what I think it was really life-changing for a living kidney donation, is that you use these donors for kidney paired programs, because you need as much donors as you have to start new change. And in our experience in Portugal, it's small, but it was really, I was really surprised when this happened. We had one first altruistic donor. It was announced in the news, and the day after, we were receiving a lot of calls for our hospital of people that wanted to donate. So now we have, I think, 3 altruistic donors here that started this. But each hospital, the legal frame in unspecified donation is really strict. I think it's comprehensible.
Thank you.
May I just ask a short question from Professor Yamanaka from the Japanese point of view regarding ABO incompatible transplantations? So could you just elaborate a little bit more on your experiences regarding the ABO incompatible transplant? Because if I'm not mistaken, you have a lot of experience in that. Thank you. Unfortunately, you are muted again. I'm sorry. Yeah.
In Japan, ABO incompatible kidney transplantation is relatively common. Could you sorry.
Are there any differences between the survival regarding the ABO incompatible and compatible transplants, kidney transplant patients? The overall survival and the graft survival, I mean, at first year or at fifth year after transplant?
Of course, ABO is bad. However, we do plasma exchange and the cause of many cases is good plasma exchange and rituximab and use rituximab. Sorry.
Okay. Thank you. Thank you. So, because we are all facing with the same issues, both from both sides. So actually, the donor shortage, and what we are using in Europe, as we can see out of the presentations, is that it's the increasing number of kidney exchange programs on a national level and on an international level. But as the ethical regulation is like quite different, then we cannot say the same from the Japanese side, if I got it well, because there are other options and other possibilities to increase the donor numbers. So yes, so here at this point, we really heard a lot of excellent an excellent perspective regarding the xenotransplantation, because there are a huge development in this field, and it was like pretty interesting. So as we still have like 2 minutes more, I just asked at last time if you would like to ask something more, or if there is no other questions, Megumi, please help me to close the session. Okay.
I realize one comment in the Q&A. I totally agree with the opinion, and it reads that there must be blinding in the operation if altruism to ensure no constraints or financial pressures. Yeah, thank you for comments, Dr. Salma Fashi.
It's one of the obligations in all even in kidney pair donation, and not unspecified. Anonymity is an absolute indication in living donation. Thank you for your comment.
Thank you. So to conclude our meeting, we have closing remarks from the president of both societies. First, I would like to invite Professor Masaomi Nangaku, the president of the JSN and vice dean and professor and head of the division of nephrology and endocrinology at the University of Tokyo, to deliver his closing remarks.
Thank you. Today, we had the entrance ceremony of the University of Tokyo Graduate School. We had the honor of hearing from our distinguished guest, Dr. Karin Markides, a renowned Swedish professor of analytical chemistry and the current president and CEO of OIST, the Okinawa Institute of Science and Technology. Dr. Markides highlighted the essential role of diversity in fostering creativity and the need for fluidity in thought and approach to truly embrace diversity. This joint seminar exemplifies such diversity, bringing together outstanding young nephrologists
who are shaping the future of our field. I'd like to express my sincere gratitude to the chairs, speakers, and participants, and especially to Motoko, Orsolya, Naoki, Christoph, and Rosa for their outstanding leadership and mentorship in nephrology. Thank you for the beautiful seminar.
Thank you. So now we will now watch a pre-recorded message from Professor Rosa Torra, the president of the ERA.
Thank you very much for your participation in this important webinar. Living donor transplantation is indeed a crucial solution for those patients in need of kidney replacement therapy. And I find it extremely useful to compare the experiences of these very different regions. Our collaboration with JSN has been always very successful, and this webinar is a true example of that. Thank you, JSN, thank you, YNP, and thank you all, young nephrologists who will lead the future of nephrology. Thanks.
Thank you, Professor Torra. And on behalf of Dr. Orsolya and myself, I would like to thank all our distinguished speakers, the leadership of both societies, and all participants for joining this valuable exchange of knowledge and experiences. We hope this meeting has provided you with new insights and strengthened the ties between our nephrology communities.
Thank you very much. And thank you for everyone for participating. Thank you, Megumi. Thank you, Professor Yanagita, Nangaku, Yamanaka. And we are looking forward to a meeting in Vienna. Thank you very much. Thank you, Rita. Thank you. Have a nice rest of the day.